Hi everyone, I'm Jae Kim, Assistant Professor at Michigan State University. Today I'll present my study titled Intersecting Effect of Disability and Chronic Health Conditions on Childhood Diversity and Resilience. The key question I ask in this study is, how do social identities, including disability and chronic health concerns, shape both risk and resilience in childhood? Before I get to my research questions, let me briefly review some key concepts from previous studies. Adverse childhood experiences, or ACEs, refer to potentially traumatic events before age 18, such as abuse, neglect, and other types of household dysfunction. They can also include community adversities like witnessing violence or experiencing discrimination. Since 1998, abundant ACEs studies demonstrated that these experiences are powerful predictors of long-term physical and mental health outcomes across the lifespan. But also, it was found that ACEs are not randomly distributed. All the previous studies reflect social inequalities. The marginalized populations in our societies are more exposed to family stress, violence, or instability in community. So, ACEs are not just individual stories of trauma. They are structural phenomena, and their impacts are often magnified for the marginalized populations in our society. On the other side, positive childhood experiences, or PCEs, capture the positive side of development and childhood experiences. They reflect experiences that promote safety, belonging, and competence, such as having supportive family, adult, feeling valued in school and community, and being part of the caring community. Previous research shows that PCs can buffer the effect of adversity and promote lifelong resilience and healthy development. But again, these positive resources are not evenly accessible. Children in marginalized contexts often have fewer chances to experience those positive and protective conditions that foster resilience and it affect their developmental trajectory. Prior research shows that race, ethnicity, gender, and socioeconomic status are meaningful predictors of both ACEs and PCs. For example, Black, Hispanic, and low-income children are often exposed to more ACEs and fewer PCs compared to their white or higher income counterpart. Also, research shows that intersectionality matters. Studies have demonstrated that identities such as race and ethnicity, gender, socioeconomic status, and sometimes gender identity intersect to create cumulative risk across a person's lifetime. Yet, one identity is largely missing from this intersectional conversation, which is disability and chronic health concerns. Evidence shows that children with disability experience 3 to 4 times higher risk of abuse or neglect and or other types of ACEs. However, disability is rarely treated as a social identity in intersectional research, and it's still too often viewed only as a clinical or medical category or conditions. So, this study asked two main questions. First, does the risk of disability or chronic health condition predict exposure to ACEs and PCs in children and adolescents? Second, how does disability interact with other social identities such as race and ethnicity, gender, and poverty in shaping these outcomes? In short, can we move beyond viewing disability as a medical condition, or instead understand it as a social construct, social identity dimension of inequality in childhood that generate the risk and resilience? To answer these questions, I used data from the National Survey of Children's Health in the year of 2021. It includes more than 63,000 children and adolescents from age 5 to 18 across the United States. This data provides an opportunity to study both ACEs and PCs together, along with detailed demographic information. Four key social identity variables were used for this study. Race and ethnicity was categorized in white, Black, Hispanic, Asian, and others. Gender in male and female. Poverty status in poverty and non-poverty. Disability or chronic health risk in those with special care needs and not. And in the study, disability or chronic health risk was measured using this screener within the dataset, which identifies children who have long-term needs of health care because they have long-term needs for prescribed medication to manage their health conditions or using significantly more health services or educational services than because of their health conditions compared to their peers, or they require specialized types of therapy, or they have significantly more functional limitation because of their health condition. For the analysis, I combined two statistical approaches. First, I used OLS regression to test the main and interaction effect of risk of disability health concerns and other social demographics factors on ACEs and PCs. Second, I applied a method called MIDA, the multi-level analysis of individual heterogeneity and discriminatory accuracy. MIDA models or combinations of identities. In this case, it should be 40, but I ended up combining the groups of two groups into Asian poverty with disability group, regardless of gender, because of the small n size. So for the current study, 39 intersectional strata defined by race and gender, poverty and disability risk were used. This approach helps us determine whether inequalities are additive, meaning they stack up, or synergistic, meaning they interact in unique or duplicative ways. So essentially, MIDA tells us whether disadvantages or risk of experiencing more ACEs and fewer PCs simply accumulate, or whether some intersections create extra vulnerability beyond what we'd expect from each identity alone in isolation. So here are the results. Let's begin with ACEs. From OLS regression, we can see that disability and long-term health concerns risk emerged as powerful independent predictor. Children with disabilities reported significantly more adversities even after controlling for race, gender, and poverty. And each social identity also added risk of experiencing more ACEs, being living on poverty belonging to a racial or ethnic minority, or having disabilities or long-term health concerns were all associated with higher ACEs exposure. Also, the interaction terms between, health concerns and other social identities were mostly significant, indicating that inequalities tend to multiplied or amplified rather than added up. So children's experience of ACEs appear to follow some amplified patterns of structural disadvantage. Looking at the MIDA model, when disability was added to the analysis, we can see that the proportion of explained variance, or PCV, rose from almost 59 to 90%. And this approximately 5-point increase means that disability contribute unique explanatory power beyond race, gender, and poverty alone. And the residual interaction specific variance was only about 2.3, meaning that most inequalities are additive. It doesn't show us any interactions, dramatic interaction. And more, the estimate shows that race and ethnicity, poverty, and long-term health concerns or disability were all significant predictors, with health concerns showing the strongest effect. Here we can visualize the pattern. The graph shows predicted ACE score across all combinations of social identities. The highest predicted ACE score, about 2.8, appeared among other race, poor, male children with disability. The lowest score, around 0.3, was found among Asian, non-poverty, non-disability male group. And we saw in the table that groups with disability and poverty and minority ethnic or racial status were more likely to experience ACEs compared to their counterparts. And these combinations actually are the predictors of increased ACEs experiences. And this pattern is linear and cumulative. The more structural barriers a child faces, the greater their exposure to adversity. And each social identity contributes another layer to the inequality. Now, let's turn to positive childhood experiences. Here, the story flips, but the structure remains. Disability and poverty were associated with fewer positive experiences. Race and gender played smaller but consistent roles here. White and female children tended to report more supportive relationships and environment. Once again, interaction patterns are observed. Children with disability or long-term health concerns facing multiple disadvantaged identities had lower access to protective context, and it was magnified. Here we can see the result from MIDA score related to PCs. When disability was added to the PC model, the explanatory power increased from 93.7 to 95. So again, disability or long-term health concerns contribute meaningfully to understanding inequality that we are seeing in PCs. And all the identity variables, race, gender, poverty, and disability status or health concern, significantly shaped PC scores. However, unlike the ACEs model, health concerns and disability were not the strongest predictor here. Instead, poverty status and some races were somewhat stronger predictors of access to positive experiences in childhood. This graph shows the predicted PC scores from the MIDA model. We can clearly see that certain groups, especially those who are white, non-poverty, and without disability or health concerns, and female have greater access to protective and enriching experiences in their childhood compared to their counterpart. The lowest predicted PC score, around 3.3, was observed among Asian poverty with these children with disability, while the highest, around more than 5, appeared among white, non-poverty, non-disability female group. These consistent patterns show that social advantage and disadvantage operate in both directions in, increasing the risk of ACEs and decreasing the chances of PCs. It determines not only exposure to adversity, but also access to protective factors. So we can see that disability and long-term health concerns functions as a distinct social identity, shaping children's life chances, both in risk and in resilience from their childhood. To summarize, this research offers some key takeaways. First, disability and chronic health concerns are significant independent predictors of both ACEs and PCs from childhood. Second, inequalities are additive. Multiple social identities should be considered all together in understanding an individual's childhood trauma and resilience. Third, reconceptualizing disability as a social identity rather than a purely medical condition broadens our understanding of intersectional childhood inequality, especially in childhood trauma and resilience, which allow us to predict long-term life developmental trajectory. From this practice, from a practice perspective, we need to keep in mind that first, trauma-informed care must be disability inclusive, addressing functional limitations and educational and emotional accessibility for those with long-term health conditions or disability. Second, policy effort should target structural inequalities connected to chronic health concerns, poverty, and the marginalized groups to um, bridging the to bridge the resource gaps. Third, ultimately, childhood adversity and resilience mirror the social structure. Building equitable and equal systems of care requires acknowledging all social identities that shape children's lives and opportunity. Thank you very much for your attention to my presentation. I really appreciate this opportunity to share my work, and I'm happy to take any questions or comments. So if you have any questions or if you have any comments, you can reach me at the email address in the slide. And thank you very much.